Assalamualaikum and very good afternoon. Welcome to the Department of Pharmacy Practice, DOPP Learning Series 3, Hospital and Community Pharmacy Practice. This webinar is held to fulfill the requirements for the course Hospital and Community Pharmacy Practices intended for Masters in Pharmacy Practice students. But this is also for others, because with this webinar, all of us will expose and provide the information on the medication, therapy, adherence screening in short, and check, and its challenges for implementations. Well, our first speaker is Mr. Devanraj Nagaraja. Let me introduce him to you all. Mr. Devanraj graduated from CSI in year 2010 and obtained his Master in Clinical Pharmacy from Liberty Science Malaysia in 2019. He was with HKL since 2010 up to now. Currently, he is ward pharmacist specialized in cardiology pharmacy. So, let's welcome our first speaker, Mr. Devanraj Nagaraja.
Good afternoon, everyone. Thank you for the kind introduction, Dr. Hasna. First and foremost, thank you for the opportunity. I'd like to thank Dr. Madhu, Dr. Hasni for the opportunity. So today my presentation will be on what is the role of pharmacy in cardiac rehab program. Right. So we will be looking at why do we actually do a cardiac rehab program? Who is it catered to? What is it actually? And what is the role of a pharmacist in cardiac rehab program as an overall arch? And why is there a need for us to extend our service into an MTech, which is cardiac rehab MTech, which we have introduced this year officially. And for cardiac rehab MTech, we will see what is the actual need to have a cardiac rehab MTech, what is cardiac rehab MTech, and what have we achieved so far with cardiac rehab MTech. And last but not least, we will look at some of those case studies where pharmacists played an active role in identifying PCIs. So coronary heart disease. As you all know, coronary heart disease develops when your coronary arteries become narrowed by cholesterol, causing the formation of arteriosclerosis. And this arteriosclerosis, which is made up of plaques, easily breaks apart with the flow of blood in the vessel, forming blood clots. And this blood clot in turn will cut off blood supplies to the heart muscle, and a section of the heart muscle where the blood has not been flowing adequately will cause it to infarct or to die. And this complete blockage is the one that causes a heart attack in layman term. And of course, in medical term, we call it myocardial infarction. So as we look at the disease progression, they have postulated in 2004, ischemic heart disease is the highest cause of death among patients. And when they did postulate to 2030, it still remains as the leading cause in death among patients. Coming back to our own home, Malaysian statistics show that the incidence of cardiac PhD is 150 per 100,000 in population, and acute coronary syndrome, 50% will have it. If you look at the mortality rate within 1 year of being diagnosed with MI, at an age of the patient more than 40 years old, 18% of men is expected to die and 23% of women is expected to die. This is just a mortality rate postulation. So why do we need cardiac rehab program? So cardiac rehab program is for those who have already experienced a major event, a major cardiac event, a major myocardial infarction. So this program is vital as a secondary prevention of cardiac event. So cardiac rehabilitation is defined by WHO as the sum of activities and intervention that is needed to provide the best possible physical and mental and also social conditions for patients so that they resume their proper place in society, meaning that they will be able to go back to their routine. And we look at the three main components of a cardiac rehab program. The first being education, where we educate the patient on their heart condition. What is it? What are the risk factors that are involved? And what are we doing to treat it? Secondly, we provide counseling. So this counseling will be from a pharmacist point of view, the pharmacotherapy, from dietitian point of view, the dietary intake that is suitable for them, and many more. And also the main important thing for cardiac rehab program is the prescribed exercise training that is done by our physio team, which will actually improve their mobility and in turn cause them to go back to their normal usual physical status. So in the cardiac rehab program is actually a multidisciplinary approach, in the sense there are 6 main components that we usually emphasize on. One being smoking cessation, exercise, diet, education, behavior, and when it comes to pharmacy, of course, we will look at the pharmacological therapy. The multidisciplinary team members, of course, is made up of doctors, nurses, pharmacists, physiotherapists, dietitians, and occupational therapists. So what is the role of a pharmacist in cardiac rehab program? So before that, the cardiac rehab program has 3 phases: phase 1, phase 2, and phase 3. So phase 1 is acute care, where the patient is still in the ward, is being admitted for myocardial infarction, and once patient has stabilized, we will reinitiate the acute care, which is phase 1. Phase 2 is when they come back for follow-up for the first 1 to 2 months. The follow-up is more frequent in terms that they will come in every week to attend each module, and one of the modules will be a pharmacist module. And phase 3 is when they go back or when they are discharged and they cared for as outpatient in cardiac clinic. This is where we have emphasized the role of cardiac rehab MPAC. So in phase 1, a pharmacist will actually, this is the first time they're encountering the problem, the cardiac event. So as a pharmacist, what we do, we ensure that they understand what are the medications they are taking, the importance of compliance, and this is usually done during discharge, and we will ensure that they are compliant and they understand before they go back that these medications are vital for secondary prevention of cardiovascular events. In phase 2, where they come back to us after 2 weeks or 1 month, depending on the availability of the slot, usually one slot of this cardiac rehab program seminars, we call it, or talks, will have 10 to 15 patients. So they will come every week, and every week they will have to attend a module. So depending on how they arrange it, so the first module will be like a pharmacist will give a talk. So when we give a talk, we will emphasize back on the role of medications, what are each medication for, how to take it, what are the expected side effects, and what are the do's and don'ts when you are on pharmacotherapy. And it will be followed by other team members. So when it comes to phase 3 CRP is when patient is managed as outpatient. So after they have completed the CRP program in the ward for a period of 1 month, they will be sent to the cardio clinic where they will be again managed outpatiently. Here as well, the pharmacists have a role in which that we can collaborate with the doctors to manage the pharmacotherapy of patients in order to prevent another episode of cardiovascular event, And of course, we want to optimize the pharmacotherapy in terms of safety, cost effectiveness, and quality, as well as we want to empower the patient in terms of knowledge. So they should know what medications are they taking and what for are they taking the medications. And it's also vital for us to ensure that they improve and sustain adherence towards those medications. So next, we will look at cardiac rehabilitation MTech. So as I mentioned just now, cardiac rehabilitation MTech is done at phase 3 of CRP. So the reason why we are doing a cardiac rehab MTech is we find that there is a role for pharmacists to play, especially in an outpatient setting, as I have mentioned before. So what is an MTech? Before going in detail to cardiac rehab MTech, we should understand what is the concept of an MTech. So an MTech is Medication Therapy Adherence Clinic. Medication Adherence Therapy Clinic is an ambulatory care service which is provided by pharmacists to patients in hospitals or health clinics. And why is it done is to ensure patients actually understand what are the medications they take, and of course to ensure that they are compliant to their medications. So why is that we think that there is a need for CRMTech? First and foremost, in the secondary prevention of myocardial infarction or cardiac event, it is found that this 4 group of drugs is very vital in terms of preventing mortality. So if we remember the earlier slides, it has shown that 18% of male patients are expected to die in a year's time, whereas 23% of female patients are expected to die within the first year of being diagnosed with myocardial infarction. So by giving these 4 group of drugs, we ensure that the mortality is reduced. So this study has shown that when these 4 drugs are on board, 3% per year mortality is reduced over a period of 10 years. But the problem is, another study showed that these medications are either not properly prescribed, or it is, when it's prescribed, it is not being taken by patients properly. So as you see in this chart here, the during part, you see that the percentage of the medication, especially aspirin, ADP antagonists like Plavix and ticagrelor, beta blockers, ACE, ARB, and statins are very high. But then when you see upon discharge, the drug use is almost half. These are the medications that are used for symptomatic relief. Again, the same issue is being encountered when we looked at the NCVD database. So the issue is medication adherence. On average, 1/3 to half of MI patients seems to be not compliant to their treatment regimes. And when they are not adherent to their medication, mortality risk is very high with MI patients. And we don't take, there is 2 times the risk of you getting a subsequent CV event. Okay. So cardiac rehab MTech, this is where the cardiac rehab MTech comes in terms that it has been made official last year, 2020, when we submitted the protocol. And why is it? We even did a local study that actually shows that CRMTech, which we have been running in HKL since 2009, has actually improved patients' lipid profile, especially LDL, which is a main parameter to show that patient is either at high risk or moderate risk of getting a second episode of MI or ACS event. And also it has shown to improve medication adherence among our patients. So what is actually cardiac rehab MTech? So just a brief history on our CRP involvement. So CRP was actually started in HKL since 1980. So it has been there for some time, but pharmacists have been joining the program, CRP, especially like what you've seen in the phase 2 CRP group counseling since the 90s. And in 2006 is when we started joining the CRP clinic, where we go to the clinic together with the doctor and we see the patients. But in 2019, we were thinking, okay, why not we establish an MTech-like service itself, and we see our own patients together with the doctor. So this CRM Tech service is actually a pioneer service in Malaysia. And of course, you can't work in silos. So what we did, we decided to write a proper protocol so that everybody else may benefit from it. And in 2020, we were able to publish the protocol, and it's available in the Bagian's website, Bagian Pharmacy website, and you can have a look at it. So this is where we do it together with the doctors at every Thursday. So what is the scope of service for cardiac rehab and tech? It is actually based on a great clinic day. So each hospital will have their own clinic day where they will see CRP patients. Since our service is based on teamwork, so it is best to do it together with the doctors. So it is not working in silos, or it's a stand-up or stand-alone service. This has to be done where the other team members are also available. So in HKL, we do it every Thursdays, 2 p.m. to 5 p.m. together with the doctors, and sometimes we do have dietitians and physiotherapists joining us. So follow-up of those patients is actually based on the CRM Tech schedule, which actually follows the clinic schedule. So what are the activities that we do? It includes medication history taking, counseling on your medication therapy, compliance and disease, lab results, and adverse drug reactions that are possible, and of course optimization of the drug. And if your center or your healthcare center allows it, you can even dispense the medication to the patient. So outcome measurement for CRM Tech primarily is, of course, compliance, which is with every services. The primary goal is to ensure that patients are compliant to their medications. But exclusively for CRM Tech, we will always look at our LDL goal. Okay, is to ensure that patient is having LDL level that is recommended by our guideline, which is 1.8 below, or 50% from the point they had a cardiac event. So that should be their goal. And left ventricle ejection fraction is also measured to see if there is any progression of patients to heart failure. So ideally, the ejection fraction should be more than 50. And of course, we want to see whether they understand the medications they take. And of course, we will look at other clinical parameters such as blood pressure, heart rate, and all that, because the medications that we use also influences the blood pressure, heart rate, and etc. And of course, if they are still smoking, we want to ensure that they cease smoking. So smoking is a very big modifiable risk factor for cardiac events. So we have documentations for each follow-up. We will go through it in a while. So standard operating procedure for the clinic involves 8 main stages. So the first stage is selection of patients. Ideally, we want to select all the patients that come to CRP program, but then emphasis is given to certain patients because one, the number of patients may be a lot, patient looks a lot, and of course, we will always want to emphasize quality over quantity. So we identify patients who really can benefit from our services. So the main 3 that I want you guys to focus on is, of course, this main 3 that is highlighted in red. We want to follow them throughout. So one being they have uncontrolled cardiovascular risk factors, even with optimum medication, and they have very low adherence to medication. They are not compliant. And of course, their total cholesterol is more than 1.8. And the goalpost for this goal is always moving lower and lower. If you look at the newest ESC guideline 2019, they are advocating 1.4. And they are also saying that if, let's say, patient has 2 episodes of cardiovascular events in 2 years, the LDL goal should be less than 1. So we have to, agree, and they should know that the goal of the LDL, if let's say it's uncontrolled, then best possible for us to see them, right? So registration, of course, once we have identified the patients, we want to be able to identify them at each visit. So they will be given a unique CRM tag number. The CRM tag number is actually written in form and also is written on the patient's file so that we can identify them when they come to us. So where do we operate? Of course, it's necessary for you to have a distinguished area where there is minimal interruptions so that it is to ensure that the patient's privacy and confidentiality is maintained, because as per our experience in HKL, the clinic is very busy. So sometimes when a patient goes into a room, there is 2 doctors, and the 2 doctors will be seeing each patient for themselves. So there is no privacy and there's no privacy for the patient. So when they come to us, we have encountered this, that certain things that they don't tell their doctors, they do tell us. When you are able to have an area for only you and the patient, they are more comfortable and they'll be able to open up more to you. So they will be able to tell you if they are experiencing any out of the ordinary effects such as GI pain or even headaches and all that. So they'll be more open to you. That's the reason why the area should have minimal interruptions. So for those with scheduled patients, the case notes, if you are able, it should be reviewed before seeing the patient. So when you have an area for yourself, you'll be more comfortable in having time, you don't have to rush to see where to sit or to have a table for yourself, because that place for you is already been fixed. So you're able to sit down, review the notes, and then call in the patients to have a session. Okay, so when you call in the patients, what do you do? Of course, you need to cater the counseling session the information that you want to provide to the patients based on patient's level of understanding. So besides giving patients points and counseling, you should also be able to give patients aids, in the sense that if you seen in the previous slide, in phase 1 CRP, there's a form there which actually enlists all the types of drugs that the patient has to take and what is the use and what do you need to watch out for. So those are examples of compliance aid or educational tools that you can use to give patient. So when patient is there, of course, you can give them all the listed information from drug name, how do they need to take, when do they need to take. Let's say they miss the medication, what should they do, what is that medication for and how does it work. And if, let's say, patient is taking any supplements or they have their dietary concerns and all that, you may even address it, or you can refer it to a dietitian. And then you must be able to recognize if there's any symptoms of adverse reaction, in particular to the patient's pharmacotherapy, so that you can do your own PCI. You can discuss with the doctor the next best course of pharmacotherapy for the patient. Of course, again and again, we want to emphasize the importance of compliance with their drug regimen, and also to come to clinic as per schedule. And monitoring and evaluation, of course, we want to see the response of our PCIs or the medications that patient is on through continuous monitoring. How we do so, we prepare a set of forms for the patients so that when they come in, you record whatever findings and lab results and what are the concerns and all that in the form. And what is actually your responsibility? Of course, as I've mentioned earlier, you need to educate the patients on secondary prevention of pharmacotherapy at initial visit. So usually the initial visit will be, you tell them what is the purpose of CRM-TAC and what is the disease that they're having, meaning the cardiovascular disease. How is it impacting? What are the risk factors that the patient has? And what are the importance of the medications they were given? Of course, we need to monitor the lab parameters and watch out for signs of any ADR. And we should refer patients to the doctor. Again, if you think that patient has suspected signs of ADR, they always miss their appointments or are very non-compliant to therapy. Of course, not just this, when you feel that the doctors or we can optimize a certain medication in patient's regime, we can always go back to the doctor and discuss with them. Then you feel that, okay, this medication should not be on board, or this medication, the dose is not sufficient, we could actually increase some more. And that kind of discussion can also take part in the clinic. Dispensing is when your center is able to dispense the patient. This is when you do your MTech in, let's say, outpatient pharmacy department, where you can, after you have counseled the patient and after you end the session, you can actually dispense the medication to them. But in the event that you are not running your services in an outpatient pharmacy department, let's say it's done concurrently in the clinic, the least that you can do is go through the prescription that the doctor have written, ensure that the medication written are all at the correct dose, time of administration, and the right drug is on board. And probably you can screen it through before sending it to your colleague in the outpatient pharmacy. So after you end the session, the patient should be able to convey back to you what they understand. And if you think that their understanding is lacking, you can always re-emphasize the points that you made to them. And sometimes you will see patients who are always missing. So when they are missing, you need to ask them why they didn't come for the previous schedule date and all that, and you have to document it. Okay, this is an overall workflow of CRM-TAC. So when you have selected the patients, you do a baseline assessment, the sense that these are the baseline assessment, past medical, medication history, any over-the-counter medications or herbal supplement products, initial lab investigation, what are the vital signs, social and family history. Sometimes patients can be as young as 30 years old, 40 years old with very strong history of cardiovascular disease in their family. Probably their parents have cardiovascular disease and occupational history, which is also vital, especially in terms of medication compliance. So this will actually give you a clue why sometimes patient is not compliant to a certain type of medication. So medication knowledge and compliance, the initial one, cardiovascular disease awareness, diet and lifestyle, especially smoking, and any allergies. So you review and you come up with your recommendations based on the vital signs lab investigations. So you set with them what is the goals and targets that you want to achieve with them. Compliance, one thing. Probably the second one will be your LDL reduction. The third one could be other baselines like your BP is under control. If patient is diabetic, the glucose is under control. And so if let's say you have any PCIs, pharmaceutical care issues, you review and you discuss back with the doctor. So they will again review, and probably there might be a change in their regimen. And then once that is done, you counsel them back again and you educate them back. And of course, it depends on what modules you want to do, because you can't tell everything at one go because the time constriction is there. So probably you can focus on one particular aspect. Probably you want to focus on the disease itself at this time, and the next visit you want to focus on the risk factors, or the following follow-ups you want to focus on the pharmacotherapy itself. So again, it is up to you. And you dispense the medication and you document what are the sessions, what are the inputs from the sessions, and what are the PCS that you have done. So in subsequent day, you contact the patient, you remind them of their appointment date. Again, if you're running simultaneously with the cardiac clinic, usually staff nurses, they will have to remind the patient. So you just need to identify who's coming in for the clinic. So you review again the CRP notes, and you see probably your patients, by this time you have your CRM tag form or file for the patient. So you again review back if there is any interventions that you need to do and all that. And for certain patients that given anti-thrombolytic agents, you may want to prepare an MI card. So once you identify the patients, these patients you can give MI card. Not just MI card, we have other cards like DAPT card, and some patients they may have underlying AF. So those patients are given anticoagulation card, and you update your pharmacotherapy form. So we will look at it. So you inform the patient if there's any changes in medication and doses. If there's any counseling required, you counsel them back again on the medication. If there's any changes, you let them know what are the changes like and what are the this. Then if you dispense, if it's separate. So this is the example of an MI card that we use in HKL. So in an MI card, you will tell them what type of ST elevated MI. So MI card is for patients who have received thrombolytic agents, because in centers like HKL, which is a non-PCI center, our first line of action when patient comes in ST elevated MI is giving them a thrombolytic agent. So certain thrombolytic agents like streptokinase, when you give it, you have to you can't give a second dose within the first 1 or 2 years. So they have to opt for the second option, which is metalase, when they are, let's say they come back again for another cardiac event. So this card provides as a reminder for the prescriber that, okay, patient have received streptokinase at particular date. So what are the options that are available? This is double antiplatelet card. Of course, when patient has a cardiovascular event, patient has to be on double antiplatelet for at least a year. So this card will indicate whether patient has what are the types of antiplatelet agent that patient is on and what is the date that it was started. Anticoagulant card is to indicate whether patient has any anticoagulant on board together with the antiplatelet. So the duration may differ. If patient is on triple therapy, we call it. So usually the antiplatelet duration will be shortened. So you have 3. Usually we will discontinue Plavix or aspirin after 1 month, and then aspirin or Plavix after 1 year. And usually the anticoagulant will be for lifelong. Or certain patients will be on anticoagulant for a set period of time, like say for DVT and PE and V-clot. So this card is to actually inform the prescriber or inform the pharmacist that patient is on anticoagulant card, anticoagulation therapy as well. So this is the form that we use when patient comes in for his first visit. As you see, the first part of it is demographic details, and then you have your social history and allergic history. What are the diagnoses? Whether patient is given thrombolytic agents. What are the patient's medical history, and what is the medication list before we enroll them to cardiac rehab MTech. And in follow-up forms, we have this, which we do defeat scoring. Of course, as you know, modified Morisky scale is no longer used. So we use this to gauge patients' compliance. And of course, the laboratory results. So as you can see, not every parameter is required. Only that is important pertaining to the pharmacotherapy of cardiovascular is listed down. And this is the follow-up counseling checklist. So these are the points that you have to inform patients when they come in. And of course, if there is any issues pertaining to patient, you write it down and what is the outcome with it. So your subsequent visits, your colleagues will know what were the issue with these patients. So what have we achieved with CRM Tech so far? So as you know, lipid management, you've been hearing me saying that we are emphasizing on LDL so much. Why is it so? It's because of this. The relative risk of cardiovascular disorder reduces by 30% for every 0.75 millimole liter of LDL we have reduced. So this makes it the most vital parameter that usually we look at to prevent a secondary episode of cardiovascular event. And with our CRM tech, we have seen that the reduction is more significant compared to a normal clinic visit. And also, medication adherence has shown major improvement in patients with cardiac rehab MTech compared to the usual care. And also, patients are more motivated, indicated by the green here, and also they are very highly motivated compared to those who are not on cardiac rehab MTech services. And as you can see here, patient is more adherent compared to those who are not under cardiac rehab MTech. And patient has more, awareness on the harmful effects of smoking that eventually causes cardiovascular events when we are with CRM tech. And of course, most significantly, patients receive all the vital group drug class that is required to prevent another episode of cardiovascular event, which includes antiplatelet, beta blockers, ACRB, and anti-lipidemic agents when patient is on CRM tech, because you have a pharmacist there to counter check whether patient is on or whether patient who are supposed to be on that particular pharmacotherapy drug class is actually on. So coming to the end of the slide, I would just like to share two case studies in which the pharmacy have done some intervention. So the first study case is actually a patient is a 49-year-old male who is actively smoking, was diagnosed with anterior amyloid, and he was given IV tenecteplase. So he was diagnosed in June 2013. So he came for the first visit in CRM Tech in September of the same year with this set of medication. As you can see, it's not complete yet. So when first patient came in, patient complained of unresolved dry cough since discharge, especially early morning, and it's very bothersome. So we were able to identify that probably the main causative agent could be ACE inhibitor. and we have suggested that the ACE is changed to an ARB group. And then patient comes again for the second visit. In this time, we saw that the heart rate was uncontrolled. So we suggested to add beta blockers. And then when patient came in for the third visit, patient was compliant to the medication. Patient were more motivated, more knowledgeable, because patient has no unusual symptoms or adverse drug reactions. And then we didn't stop at that. We ensured that the medications are optimized. As you can see with bisoprolol, the optimized dose here is 2.5 mg OD. Second case is a patient, female patient, who has underlying DM, hypertension, is smoker, came in with inferior MI, was given IV streptokinase, again in January 2013. She was discharged with this set of medications. And when during the first visit of cardiac rehab and tech, she complained of disturbing headaches with discharge. So we were able to identify, okay, it's index. And she also said that I don't have any chest pain. Right? So index itself is not required. At the second visit, she said there's no more headache. She was adherent to a prescribed medication, but we see that the lipid profile did not improve. So you see here the LDL is 3.7 and it's 3.6. And when we saw the medication list, we identified that the statin was not optimized. So if we look at your 2017 lipidemia guideline, patients who had a cardiovascular event, they should be on high intensity statin. So that's why we started atorvastatin. And besides that, we saw that, okay, perindopril is 2 mg. We can optimize it to 4 mg OD. And the third visit, patient's knowledge and adherence to the medication was good. And we saw the LDL is coming down, although it hasn't reached the targeted range yet, but we could see that the trend is coming down. So we told patient to continue with the medication, and we also optimize patients' bisoprolol to 2.5 mg OD. So in a nutshell, this is how we do our PCI, and of course, these are the contributions of a pharmacist in cardiac rehab clinic. So these are some of the guidelines that you can have a look, which is very much vital and pertaining to the management of secondary prevention of cardiovascular events in patients. With that, I'd like to thank you, and I'll take any questions that you have. Thank you.
Thank you, Mr. Devanraj.